Look, today I wanted to talk about failure to thrive, and as I said, the failure to thrive is it should be really fundamental to paediatrics, and so many of the patients we look after have the early stages of failure to thrive, but we often don't recognise it until it's reached a point of severe malnutrition. And so I wanted to talk about terminology a little bit. One, we talk a lot about severe acute malnutrition, SAM, and there's been lots of training on that, but often severe malnutrition that we see is not acute. And even so, we should be identifying SAM before it's really severe. So it's often not acute, and we'd like to see it before it's severe. So that means identifying it when the child is failing to thrive. And this is a typical growth chart of a child who's failing to thrive. And I think what's useful on a growth chart is to try to write down, if you can, key events that happen. And so with this child, was born at 35 weeks gestation, so was a bit preterm, and the weight was already on the 3rd centile. Then the baby was exclusively breastfed for a couple of months, which was good. But then at 4 months, there was complementary feeding introduced with some formula. And then the baby had a hospital admission for 5 days at 8 months with diarrhea and fever, and then another hospital readmission with diarrhea and cough. And by that stage, the child was identified as having severe malnutrition, thought to be severe acute malnutrition. But in reality, the baby had been failing to thrive since around about 8 months. She was always a small child. She was born preterm, and so she was always small. But you can see where the centiles drop off at around about 8 months, just after that first hospital admission. And yet it took until she was 2 years to identify her as having severe acute malnutrition. This is a real case, and I think it just illustrates that we miss failure to thrive, and we diagnose it when it's severe acute malnutrition. Now, failure to thrive can have multiple causes, most of which is primary malnutrition, but there can be sometimes there's an interaction between primary malnutrition and chronic illness. And many children who have primary malnutrition because of inadequate energy or food intake or inadequate absorption may also develop intercurrent infections that are prolonged, and that makes their malnutrition worse. Occasionally, you'll see a child with failure to thrive who has a genetic or syndromic cause of failure to thrive, but most of it's this combination between primary malnutrition and chronic illness. And all children with failure to thrive have combinations of inadequate energy intake, inadequate absorption, sometimes increased energy utilisation if they've got a chronic inflammatory condition where they're using more energy than normal. And often there's psychosocial factors within a family in a child who's failing to thrive. Not always, but often there is. And as I said, there's often multiple factors contributing to failure to thrive, and it has a very big impact on a child's development. When I said there's all these different potential causes of failure to thrive, inadequate energy intake, inadequate absorption, increased energy utilization, psychosocial factors, or sometimes genetic or syndromic causes. I think it's useful to think about what the actual problems are that might cause inadequate energy intake, such as breastfeeding difficulties or inadequate complementary feeding. In our case, this was a child who was preterm and was breastfeeding, but had complementary feeding introduced at 4 months and clearly didn't have adequate complementary feeding. And that is sometimes because of inadequate volume of feeds, like the baby's not just feeding enough, or sometimes it's inadequate number of feeds. A baby who's only fed 3 times a day. So inadequate volumes of feeds or inadequate number of feeds. Almost always there's a lack of dietary diversity. And so it's usually a combination of all of these things: inadequate complementary feeding, low volume feeds, reduced number of feeds, lack of dietary diversity when the baby's complementary feeding. Sometimes there's prolonged exclusive breastfeeding. So instead of introducing good quality complementary feeding at 6 months, there can be exclusive breastfeeding beyond 6 months and no other solids introduced, and that can lead to failure to thrive. Sometimes if a child also has a chronic illness like TB or HIV or any other chronic illness, then they may have anorexia or inadequate absorption of food energy because of that. And sometimes there's structural causes of inadequate energy intake, like a cleft palate. And sometimes when mothers are formula feeding their babies, there'll be errors in the infant formula dilution. And so all of these things need to be considered when you're thinking about whether the energy intake of a child is adequate or not adequate. Then there are many reasons why a child might have inadequate energy absorption. Even if they're taking in enough calories, enough energy, then they may still have inadequate energy absorption because of chronic diarrhea or because of a condition called environmental enteropathy, where you get a bacterial overgrowth of the gastrointestinal tract, and that can lead to a chronic diarrhea. Sometimes there'll be helminth infestation, like with hookworm or other worm infestation, that will lead to nutrition loss and also lead to energy consumption. So the worms, if they're abundant, they will consume a lot of energy from the food that's taken, and therefore there won't be enough energy to be absorbed. And then there's some other conditions like celiac disease or cow's milk protein intolerance, where there's a condition, an enzyme deficiency that leads to impaired tolerance of either gluten in celiac disease or cow's milk protein or lactose in cow's milk. And then some children will have a chronic inflammatory bowel disease, or they may, because of their recurrent infections, have antibiotic-associated diarrhea. And then there'll be some children who have immunodeficiency, and that can either because of HIV or some sort of congenital immunodeficiency, and that will lead to reduced energy absorption by the gastrointestinal tract. So I go through these because each child needs to be considered as to whether or not they might have one of these factors involved in their malnutrition, in their failing to thrive. Then there are some children, of course, that have increased energy utilization. So no matter how much you feed them, they will have higher energy requirements, such as if they've got a chronic illness like TB or HIV, or some children with congenital heart disease, they'll use up more energy. The other problems are relatively rare. And then overlying all of that in many children who are failing to thrive will be some sort of psychosocial problem within the family. And we all know that children who are adopted are a bit more likely to have failure to thrive. But there are many children that have this combination of being adopted or neglected, or coming from families where there's dysfunction or domestic violence, or they may be an orphan, or the parents might be ill, or the mother might be depressed. A lot of psychosocial factors that really need to be understood if you're going to understand this child's failure to thrive. The parents may have a poor understanding of nutrition, or they may just live in abject poverty. A lot of reasons why a child might be failing to thrive. And as you can see, it's not one reason that applies to all children. There is likely to be a number of these factors involved in any child's failing to thrive. And then occasionally you see a child who's got a congenital or genetic abnormality like a skeletal dysplasia or a chromosomal abnormality, and that's one of the reasons why they've got failure to thrive. But when you see a child, with failure to thrive, try to think of these different areas, these different causes, and the factors that might be involved in the child's failure to thrive, and really try to understand that well. And you can do that from taking a good history and doing a good examination. You don't need any special tests. It's really often requires several history and examinations to get to the bottom of why a child's failing to thrive. And sometimes it requires an admission to hospital or observation over a period of time, many days or even weeks. The same girl that I showed you before, who was failing to thrive in terms of her weight gain, was also, when her head circumference was plotted, was also having crossing centiles in regard to her head circumference. So when she was born, she was not too bad on the -1 to -2 standard deviations, but from about the age of 8 months, her head circumference started crossing centiles. So her head had very limited growth. And that is a late sign of failing to thrive. By this stage, she'd already started to cross centiles with her weight. Usually, failure of head growth takes a bit longer to identify. But typically, when a child's failing to thrive, their weight gain is affected first. But if the problem persists, if it's not addressed, then their length is also affected. They get stunted. And then their head circumference is only affected when the failure to thrive is severe, and usually when it's prolonged. So if we're going to try to pick up failure to thrive early, we need to look for weight that's crossing centiles, or if a child's losing weight, or there's developmental delay. And each of those things will be pointers towards failure to thrive. But you need to be looking carefully at weight charts to see when a child crosses centiles. And sometimes that can be difficult. In this case, the weight curve just really flattened out. It's already crossed the third centile, below the third centile, but it really flattened out. So a flat or falling weight curve is an indication of failing to thrive, and we should try to pick it up early. Now, I mentioned that the underlying causes of failure to thrive can be identified by taking a good history, and sometimes it's difficult to work out just how to take a history, how to take a nutritional history. And I think there's at least 2 ways that you need to take a nutritional history. And the first one is what's called a longitudinal history, and that is you start from birth and find out whether the baby was breastfed from the time of birth, whether they're exclusively breastfed, what the mother's milk supply was like, when, did she give the baby colostrum or not, how long was the baby exclusively fed for, when complementary feeds were introduced, what type of complementary feeds, etc. And so you're taking a very detailed history from birth to, depending on how old the child is, right up until the child becomes unwell. And then also it's useful to take what's called a cross-sectional history. So that was a longitudinal history, but it's useful to take a cross-sectional history. And I usually say, well, in a typical week, what does your child eat? And that's easier for mothers, I think, to understand than saying, well, does your child eat meat? Well, yes, the child eats meat, but it might only be once a month. But you can ask on a typical day or in a typical week, what does your child eat? And sometimes it's useful to have like a 3-day feeding diary where a mother, if she's literate, can record the feeding that she provides to the baby over a 3-day period. And you can then determine whether or not the complementary feeding that the baby's receiving is adequate, or the number of feeds, or the volume of feeds, or the diversity of the diet is adequate over a 3-day period. So that's a cross-sectional history. So a longitudinal history, looking at a timeline from birth to however old the child is, and then a cross-sectional history on a typical day or a typical week. What does your child eat? And trying to understand these issues that I talked about before, about the frequency of feeds, the volume of feeds, the diversity of the diet, etc. You then need to do something like a sort of a nutritional systems review and ask about other things like vomiting and diarrhea. Is there signs of malabsorption or not? And is there other features that might indicate a chronic infection that's causing either anorexia or reduced absorption of energy, or increased energy requirements. So has the child got fever or lethargy or cough or irritability that might point towards a chronic organic illness causing the failure to thrive. When you examine a child, then I'm sure you know how to look for signs of malnutrition. So look for wasting, usually of the muscle bulk of the buttocks and thighs. Look for edema. Often, like this baby has very prominent ribs, you might say has got chest indrawing, but actually didn't have respiratory distress, just has intercostal muscle wasting. Do the mid-upper arm circumference. Look for sparse hair or a very sort of bony, skeletal-like face. You can look for dysmorphic features too, in case the child's got a syndromic cause of failure to thrive. Look at the mental state of the baby. Many babies that have failure to thrive will be apathetic, or they'll be withdrawn. They won't be happy, smiling. They may be withdrawn and not making good eye contact with the mother. I'll say a bit more about that shortly. Look for evidence of chronic disease. So look for any clinical features of TB or HIV, such as generalized lymphadenopathy or hepatosplenomegaly, or other signs like opportunistic infections like oral thrush or something like that. Look, as I said, for candidiasis. That might, it's not uncommon for children to have a bit of oral candidiasis, but if it's really thick plaques in the mouth and in the throat, then that suggests an immune deficiency of some sort, and it can suggest HIV, or it could suggest some other chronic immune deficiency. I find it useful after you've done an examination to make some while a child's in hospital, to make a direct observation of the child's feeding. And when you do that, you can look at how often or how strongly the child demands feeds, and then you can look at techniques of feeding, how the mother feeds the child or the father. Look for coordination of sucking and swallowing, I mean, to make sure that those structural mechanisms of swallowing are adequate. Sometimes I even video or ask the mother to video when the baby's feeding, and you can get a bit of an idea about how well the baby wants to be fed, what their techniques of feeding are like, etc. And then you need to do a developmental assessment. So any child with failure to thrive needs to have a proper developmental assessment. Now, when you're doing a developmental assessment, you need to, especially in a child with failure to thrive, you need to look at their gross motor function. And many children with failure to thrive, like the last child I showed you, has very poor muscle bulk and tone, and often for that reason alone, they will be developmentally delayed, because they have such small, limited muscle mass. They won't be able to do the things that a normal child who's got good muscle mass will be able to do. So look for gross motor function. Look for their mental state too. Like, as I said, whether they're apathetic or whether they seem withdrawn from social contact with the mother or with other people. So look for all of those things in relationship to the baby's mental state. And this is, I think, a really interesting illustration of a child before or while he was malnourished, and then after treatment of his malnutrition. And you can see just how much in the first photograph, he looks a bit apprehensive. He's obviously quite wasted. But in the second photograph, when he's put on weight, he's smiling and interactive and looks alert. There's a difference in the demeanor in the interaction of babies when they're malnourished and when they become well nourished. When you're looking at development, remember, you need to be able to make say something about the baby's development in 5 domains. So gross motor development, their fine motor development, their vision, their hearing, and their socialization. If you are able to examine a child and comment upon their gross motor, fine motor, vision, hearing, and socialization, then that's really all that's required for a developmental assessment. And in terms of their gross motor function, then there's a variety of different milestones a baby should have achieved by different ages, including their head and truncal control, whether they can roll or sit or crawl or walk. And it's useful to know roughly when those things should happen. So sitting, for example, should happen sometime between 6 and 8 months, rolling around about 3 to 4 months, crawling about 9 months, standing about 12 months, and walking somewhere between 12 and 16 or 18 months. It's useful to know those things, but I'll show you a quick way to do it. When you're looking at fine motor, you're looking at their arm and hand control, particularly their fine motor skills. I use a chart like this. There's many different charts, but essentially these charts show these 5 domains of development, but they show them pictorially. And you can look at the child's age and say what they can do for that given age. And so this child that I talked about before was quite good in terms of fine motor skills. So this 2-year-old was able to have quite good fine motor skills, and they could look at pictures in a book, and they could understand most simple language. But still, they were gross motor delayed in terms of they still had a bit of head lag, and they could just sit with hand support, and could crawl a little bit, but couldn't by the age of 2, still wasn't up to standing and walking independently. And so you've got a child who's got adequate vision, hearing, and fine motor skills, but you've got gross motor developmental delay because of severe muscle wasting. And so using a chart like this can help you just describe the child's fine motor skills, their gross motor skills, their vision, their hearing, and their socialization skills. I think this is a useful thing to use in whenever you see a child who you want to do a developmental assessment on. I said before about the child's demeanour, about their level of interaction, and it's been said that some sort of in-depth psychosocial evaluation is needed for all children with failure to thrive, and I think that's probably true. You can do it without being a psychologist. You can do it by just observing the parent and the infant interaction. So sometimes we see parents who are really loving and caring to their child, and they enjoy caring for the child, but sometimes the parents will be disengaged. Sometimes they will be coercive. They will try force feeding the baby, or they'll feel frustrated and upset. Now, these are all normal reactions to a child who may be refusing food or failing to thrive, or maybe irritable, or maybe sick, and the mother's tired as well. So we have to be understanding of all of those things. But it's just important to observe these things. Does the parent handle a child gently or roughly? Maybe they've never learnt how to handle a child properly, and they handle a child in a rough way. Do they have eye contact and play with the child or not? So these are I wouldn't say in depth, but they're observations that you can make. Try to make observations, but not judgments. Don't judge the parent for the way he or she is behaving to the child, but just make observations about the way they're doing it, and then try to understand why that might be. The worst thing we can do is judge parents for being frustrated about their children if they're sick. Sometimes the parents will be depressed, or sometimes they'll be sick themselves, or they may be very hungry. The parents may be hungry, they might not have had enough to eat. And so we shouldn't judge them, but we should observe the interaction between the parent and the infant and try to understand to what extent that's contributing to the baby's failure to thrive, or it's a result of it. Often we don't need to do many investigations for children with failure to thrive, and that's because if there's no clinical features suggesting an organic disease, then mostly investigations have quite a low yield. Now, it depends how severe the child is, and often these children with failure to thrive, present when they have an intercurrent infection. They don't present just with failure to thrive. They present because they've got a fever, or they present because they're pale. And so there are some investigations that need to be done. But what's more important than the investigations usually is to go back on the history and try to find out what the underlying several causes are of the child's failure to thrive. Of course, we should rule out tuberculosis or HIV, and you can sometimes do that with clinical signs and symptoms, and sometimes the child will need a gastric aspirate, or sometimes they'll need a HIV test. Often they'll need a full blood count because anemia is so common with failure to thrive. So investigations are likely to be needed, but don't forget that the most important thing is taking a good history, doing a good thorough examination, and examining for all of those other things that I've talked about, like the child's development, the parents' interaction with the child, etc. The management of all sick children follows this sort of process, doesn't it? Triage and emergency treatment, and taking history and doing an examination, looking at laboratory investigations if required. We've gone through all of these with a child with failure to thrive. And then the main diagnosis and other diagnoses. So often children with failure to thrive will have more than one diagnosis. It won't just be failure to thrive. It might be failure to thrive with anemia, or failure to thrive with chronic diarrhea, or failure to thrive with possible immunodeficiency, whatever it is. And then providing treatment and supportive care and monitoring and discharge planning and follow-up. And those stages of management can be applied to the child who's got failure to thrive or severe acute malnutrition as well. WHO talks about the management of severe malnutrition in SAM management, about these things. So about the prevention and identification and treatment of hypoglycemia, about the prevention of hypothermia, and the correction of dehydration, the correction of electrolyte abnormalities, the treatment of infection if it's present, the addition of micronutrients to a child's feeding, initiation of feeding, which should happen straight away, really. The most important part should happen immediately. And then catch-up growth, which is going from F75 to F100. And then sensory stimulation, which is really just trying to engage the child and play with the child in an age-appropriate way, and then follow-up. So they're in the stages of management of severe malnutrition. That's what we need to take account of. I wanted to talk, though, about refeeding syndrome, and I want to spend a bit of time on that, because I think if we understand refeeding syndrome, we'll understand a lot about severe malnutrition. Now, refeeding syndrome, I'm sure you've heard of it, and it's become, I think, less common in recent years. And it's become less common in recent years because the commodities for the management of severe acute malnutrition, the treatments, the formula that for management of severe acute malnutrition have incorporated many of the electrolytes that are often lacking in children with refeeding syndrome. But I want to go back and try to explain refeeding syndrome, because if we understand it, we'll understand a lot about the management of severe malnutrition. And refeeding syndrome was first described, it's existed forever, of course, but it was first described among people who were released from concentration camps, particularly in Germany, but also in Japan, after the Second World War. And what they found was on when these people, these malnourished people who are skeletal, they're often severely marasmic, when they were refed, they often developed diarrhea, they became very unwell, lethargy, often heart failure, they may lapse into coma, become very weak, and have convulsions. So you would think that once you start feeding patients, then they'll start to get better, but actually many of them got worse before they got better. And many severely malnourished people from concentration camps died of this progressive, not an illness, but these complications. And from that came a good understanding of what refeeding syndrome was and how to prevent it. And what it is major shifts in fluids and electrolytes that occur when people are going from being malnourished or starved to being fed. Now that feeding, the refeeding, can be usually artificial feeding, but it could be oral feeding. It could be feeding with a nasogastric tube. It could even be feeding through total parenteral nutrition, a way in which some refeeding happens through an intravenous drip, but mostly it's from oral or nasogastric artificial feeding. And it surprised me to really understand which patients are at risk of refeeding. And you don't have to have severe acute malnutrition to be at risk of refeeding syndrome. Any child who's got chronic undernourishment or acute malnutrition, or even being unfed, not fed for 7 days, then there's a risk of refeeding syndrome. The longer it is, the worse their malnutrition, the greater the risk of refeeding syndrome, of course. But even just after 7 days, a child can be at risk of refeeding syndrome. There are some children a bit more at risk than others. So if a child's been on long-term diuretic use, they're not more at risk of refeeding syndrome, but they're more at risk of extreme loss of electrolytes, because they may already have lost potassium and other electrolytes, from sodium, etc., from their diuretic use. And so if we see a child who's been on chronic diuretics, who when is fed becomes weak or hypokalemic or hypophosphatemic, or their heart failure gets worse, then it might be that they're also being affected by refeeding syndrome. How do we recognize it? Well, usually the earliest sign is the phosphate goes low, but we don't always measure phosphate. But phosphate, calcium, and magnesium are the electrolytes that often go very low. Sodium can go very low as well, but not as much. So phosphate, magnesium, and potassium are the 3 electrolytes that typically go low. And then there's some vitamins that go that are lost as well, go very low. Thiamine is the one. So phosphate, magnesium, potassium, and thiamine are the major abnormalities in refeeding syndrome that lead to clinical consequences. And I think to understand refeeding syndrome, we need to understand what happens in this transition of hormones and electrolytes that occurs when you go from starvation to being refed. And so to understand what happens during starvation and what happens when you're refed. In times of plenty, when we're most of the time, our body uses carbohydrates for energy. So even though we eat carbohydrates and protein and fat, usually the body first of all uses carbohydrates for the production of energy, for the production of ATP that's used for cellular functions at a cellular level. When the child's starving, the body switches from using carbohydrates, because you're not taking in any carbohydrates, to using the stored fat initially, and then the stored protein in muscle as the sources of energy. This is a transition that's very important, because the hormones that govern it are very different. The hormones that govern carbohydrate metabolism is predominantly insulin, whereas during periods of starvation, insulin levels drop very dramatically, and you have more cortisol, more adrenaline, etc., that leads to a breakdown of fat, and then eventually using protein or your muscle source as a source of energy. Yeah, the body's aim all the time is to generate enough ATP, that's the energy it needs for cellular metabolism, but try to preserve protein and muscle. So that's why protein is used last. But when we see children with severe malnutrition, they've got almost no subcutaneous fat stores, and they're starting to break down their muscle as well. The other thing the body does is it reduces the metabolic rate by even up to a quarter, which is a huge reduction in metabolic rate. And it's no wonder these children are lethargic, why they're not active, why they might be apathetic, why they're not thinking properly, is because their whole body metabolism has been reduced by up to a quarter to preserve energy, so that they have enough energy to make enough ATP just to keep the vital functions of the body going. So that's what happens in starvation. Under starvation, you have a drop in insulin, you have an increase in glucagon and cortisol and adrenaline, typically, and the energy, your ATP, comes from the mobilization of liver glycogen to break down glucose. So you use up all your glycogen stores in the liver, and then breakdown of fats, that you have fat stores, and then breakdown of protein, which is muscle. So it usually goes in that order. That leads to all the clinical features that we know of severe malnutrition, so wasting and loss of subcutaneous tissue, and hypoproteinemia, which means very low protein, so low albumin. That's why you get edematous. It leads to very reduced nitrogen levels in the blood, and glucose, phosphorus, magnesium, and potassium go very low. Now, that's what happens in starvation. When a child's refed, then they're given, if they're given a lot of carbohydrates to begin with, then they'll have a burst of insulin. And that will lead to going from catabolism, that is the breakdown of the body's stores of protein, lipid, and carbohydrates, to anabolism, which is a building up of those protein stores. And that's a good thing, that goes from breaking down protein to making new protein, which can lead to increased muscle strength and storage of glucose as glycogen when you feed patients carbohydrates. But it also leads to a number of other deficiencies. And when you're doing this, when you're making lots of protein and lots of storing lots of glucose, you're needing lots of energy to do so. And that can lead to a further reduction in phosphate. It leads to, when insulin levels are high because of the high intake of carbohydrates, then not only is glucose driven into cells, but also potassium and magnesium and phosphate and thiamine are also driven into cells to make that new protein. So again, it's a good thing that when you feed patients, they get a rise in insulin, but that can lead to refeeding syndrome, which means that all the limited stores of potassium and magnesium and phosphate and thiamine that a person has, when they're refed, then they can be even more limited, and you get dangerous levels of potassium and magnesium and phosphate and thiamine, right? And that can have consequences if you don't replace those losses. This is just a cartoon showing the same thing. Remember, in starvation, there's a reduction in insulin, but an increase in glucagon and cortisol. So you get a breakdown of lipid, you get a breakdown of muscle eventually, and you get depletion of electrolytes. When you go to feeding a patient, it goes from catabolism to anabolism. And the carbohydrate load leads to a massive increase in insulin secretion, and all of these electrolytes go into cells. So there's uptake of glucose and potassium and magnesium and phosphate and thiamine by the cells for protein synthesis and glycogen synthesis. So storing of carbohydrates as glycogen within the liver and within other cells. And that can lead to dangerously low levels of potassium or magnesium or phosphate or thiamine deficiency. It can also lead to salt and water retention. Usually, as soon as you start feeding patients, their salt excretion reduces quite a bit, and that can contribute to their cardiac failure. The effects of very low levels of phosphate, remember I said that was the first thing that goes wrong when patients are being refed. Well, it causes muscle weakness, and especially diaphragm weakness. So sometimes we see children that have respiratory failure, and part of the reason for their respiratory failure is their muscles are weak, and part of that is because they have diaphragm weakness, and you should check their electrolytes because often their phosphate will be low. Magnesium, phosphate, and potassium, are required for muscle strength. And so if those levels are low, then you may get muscle weakness, especially of the diaphragm. Sometimes these children will have heart failure, and sometimes they'll have a hemolytic anemia because the red cells are taking up a lot of water and they're losing a lot of electrolytes, so they'll often lyse. So in some children with refeeding syndrome, they have muscle weakness, they have heart failure, they have hemolytic anemia. And the reason for that is that potassium is very important for, phosphate is very important for all of the energy production. So ATP, adenosine triphosphate, it's got 3 phosphates in it. So if you don't have enough phosphate, then you can't make enough energy anyway. So it's very, very important electrolyte, even though we often don't measure it. And there's another phosphate-containing enzyme, 2,3-DPT, that is very much involved in the delivery of oxygen to tissues and the uncoupling of oxygen from hemoglobin. So when you don't have phosphate, then you have major problems with oxygenation, major problems with muscle strength, etc. So it really causes lots of problems if you've got low phosphate levels. And as I said, when you start refeeding a patient, you often get a rapid reduction in renal excretion of sodium and water, and that can lead to worsening of edema. So that's why it's very important not to give too much in the way of intravenous fluids to these patients, because they can rapidly develop fluid overload with congestive heart failure or pulmonary edema, or because of their electrolyte imbalances, get cardiac arrhythmias. So most of the new method of managing severe acute malnutrition with F75 and F100 and with micronutrients has really limited the likelihood that severe refeeding syndrome will happen. But it's useful to know the origin of why we use F75 and F100, because they've got lots of phosphate, they've got potassium, they've got magnesium, and it's relatively low in carbohydrates to begin with. F75 is low in carbohydrates. So instead of giving a big carbohydrate load, that leads to massive production of insulin and then these electrolyte imbalances, and it's a moderate level of carbohydrates. I won't go through this too much, but the reason why children can get heart failure when they have malnutrition relates to a number of things, and it can relate to their heart muscle being a bit weaker. Their heart muscle may be weakened, just like all muscles can be weaker. But more to the point, when you start feeding these patients, they may get electrolyte imbalance. So they may get hypokalemia or hypomagnesemia or hypophosphatemia. That can happen even before you start feeding them. But if they've got some sort of like skeletal muscle atrophy, they've got some sort of myocardial atrophy because of severe malnutrition, then they may have like a nutritional cardiomyopathy. If they've got low thiamine levels, if they've got other vitamins that are low, they may have a nutritional cardiomyopathy, and their electrolyte imbalances may lead to heart failure. And this is a very important thing about managing children who've got severe malnutrition, and that's why we try to avoid intravenous fluids in these patients. I'll just speak briefly about thiamine deficiency, because I think it's relatively more common in some populations in PNG. Obviously, malnourished children can be thiamine. Thiamine is vitamin B1, of course. If a child's malnourished, they can be thiamine deficient, although not all children with malnutrition will be thiamine deficient. But sometimes mothers are thiamine deficient, so if they're breastfeeding their baby, then the baby will become thiamine deficient. And thiamine is found in rice, but it's found on the husk of rice, on the coating of rice, I should say. And when rice is polished or washed, then that can take the coating of the rice off, and then what you're left with is thiamine deficient rice. And so people who wash their rice, if a parent washes the rice a lot, then that can lead to a diet that's low in thiamine. Also, betel nut has an anti-thiamine activity, so it reduces the absorption of thiamine, as does tea and coffee, but nowhere near as much as betel nut. So you can think of populations that are more at risk of thiamine deficiency being mostly people who have these characteristics. But thiamine is very necessary for making protein, and whenever when the body switches from catabolism to anabolism, there has to be a lot more thiamine available to enter cells and to be involved in the generation of ATP and in the production of protein. And so all of those the changes that happen once the metabolic rate increases because the child's fed, because there's more energy available, because they've gone from catabolism to anabolism, all of those changes require thiamine. And sometimes we don't replace thiamine, and it's very important, because if you don't replace thiamine, then there's a shift from making thiamine, making protein, to making more lactic acid. And so I'll just show you what can happen. But there's a lot of consequences of being thiamine deficient, including things like pulmonary hypertension, heart failure, severe malnutrition. So I won't go through this in too much detail, but as I've said, all the biochemical pathways that are needed once a child is refed, that is the synthesis of proteins through RNA, the production of energy, so ATP through the Krebs cycle, they all require thiamine. And if there's no thiamine there, then what happens is that pyruvate just becomes lactate, and what ends up being is that there's no protein synthesis, there's no energy or ATP synthesis, there's only the production of lactic acid. And that can lead to lactic acidosis, and the child can become very unwell without thiamine. So when you've got a child with malnutrition, you need to be replacing thiamine, and it's in multivitamins, so it's vitamin B1, but it's a very important vitamin. If you see a child who's got a lactic acidosis, then think about, could they be thiamine deficient? The best way to prevent all this is to follow the guidelines. And those 10 steps I showed you earlier, following WHO guidelines for the management of severe malnutrition, and using the guidelines on the type of feed that's given, F75 to begin with, and therefore later on F100, when the child's stable, when their edema's resolved, when they have had supplemental electrolytes, their potassium, magnesium, phosphate, when they've had their multivitamins, the thiamine, all of that it's been very well worked out, I think, and that's why following that guideline is very important. So I guess what I've tried to explain today is a bit of background on refeeding syndrome, and it helps us understand, I think, why we do follow the process of management of severe malnutrition like we do. So just in terms, going back to the start of this talk and going back to failure to thrive, remember I said we should be trying to identify failure to thrive early. We should be trying to identify the causes of failure to thrive in relationship to reduced energy intake or reduced energy absorption or increased energy utilization or psychosocial factors or genetic or syndromic factors. So if you think about it like that, then that will help. And then we should be following the stages of management of severe malnutrition, and we should be alert to the possibility of refeeding syndrome. And then I think it's useful to establish a feeding pattern in hospital that can be reproduced at home. While we give F75 and F100, parents can't give that at home, can they? And so it's important that we switch over to food that a mother, father can give the child at home. And so that they get practiced in that. For some children, a written feeding plan is important. For others, it's not so important. But there needs to be a clear plan, a written feeding plan while the child's in hospital, and a carefully described feeding plan when the child goes home. Psychosocial problems are often at the heart of severe malnutrition and failure to thrive. So we need to be identifying those and providing whatever support, psycho support or social support for the mother and for the family. And the children themselves, when they're failing to thrive, remember they're developmentally delayed and they need support for their development, both nutritional and also some early intervention support. And all of these children need follow-up for their growth and their development and whether they've had their vaccines, and sometimes behavioural problems because they have come from families in which they've been failing to thrive, and they may be at more risk of having some sort of mental health or behavioural problems in later life. So I hope that's been useful. I know you've mostly had teaching and training on severe acute malnutrition, but I wanted to just broaden it out a bit to talk about failure to thrive today and a couple of separate aspects of that. So if there's any questions, I'm happy to answer them. So I'll stop now. Thanks.